Thank you, Kevin. Certainly a great honor to be here today, and Jeff and I are going to tag team a little bit, so I'll do sort of the first of the presentation. Jeff come up and then I'll finish it out and we'll do some questions at the end. Again, really appreciate the opportunity to share some things with you today on healthcare and healthcare reform. And certainly is a topic that continues to stay in the media. There are lots of unknown that at one time in our lives, each of us need those services for one way or another. And certainly want to give us a little background on that today. You know, one of the things that I want to start with is we're going to go through sort of 4 different areas. Really want to talk about healthcare consumers and patients for a bit. Jeff's going to come up and talk about some of the current impacts of the Affordable Care Act, looking ahead with that and what's going to be happening over the next year or so. And then really I want to come back and talk a little bit more about the future of healthcare delivery. One of the things, as Kevin said, is sort of important for us to just put up here is it's obviously 3,000 pages of legislation, so we're really trying to cram that into about 20 minutes. There's still lots of unknowns there, so certainly please take the information we provide with you really is a pure overview and not action items to take from it. You know, one of the things that I look back on as a provider and say, you know, the term patient really comes from the definition that is who suffers. And when we look at what patients are, certainly as providers, we really don't see them as consumers. We see them as patients. We see them as how do we help patients get better? How do we help change behaviors that get them into a status of wellness? How do we help families? But one of the things that we're seeing is a change in the healthcare delivery environment where patients really are becoming more consumers and they're seeking services, and from a value standpoint, the things they want out of the delivery of those services is changing. And so what I want to go through just for a moment is really talk about, there are really sort of 6 segments of that a study from Deloitte put forth that I think really shows how healthcare is changing, and even from an employer standpoint, when you look at your own employees, how they engage in services, and sort of how you help to manage those costs long term. I think first you look at sort of the casual and cautious group. If you look here, I know it's hard to see and I apologize for that, but if you look at the bottom, this really represents the millennials. Sort of this 1982 to 1994 group. And that's really a group that doesn't necessarily require a lot of healthcare services, but is very cost conscious. And I think as we see things change, we're going to see that change in the types of services they demand from healthcare providers. I think the next group is sort of the content and compliant. We see that sort of as the opposite. The seniors represent that largest group. And I would define this as sort of the group, when you think of it as a healthcare provider, that's the traditional patient. They go to see the physician recommends a test, recommends a medication, and they follow that to the letter, to the best of their ability to make sure they're doing the right things to improve their overall health. The next area is really an online and on-board group. And this represents an interesting group because you would think, regardless of age, we're really seeing that regardless of age, all patients are seeking online solutions for healthcare relatively equal. It's not just a younger population that's really seeking that online information. This is a group of patients that are really coming to the physician and saying, hey, I sought this out online, I think I know what I've got, can you tell me? And then when you go through it with the physician, they say, no, I'm not sure that's right because I've got that information right here. And so it really becomes a different partnership in terms of the way patients engage and they look for solutions. This is a group of patients also who really are looking for innovative solutions to their challenges. They want to find that newest technology that's going to help them monitor their blood pressure, monitor their blood glucose, and engage in a different way. I think when you look at the next group, the next group really is the sick and savvy. This is the group that'll go along this line right here. Again, higher percentage of seniors just from an age standpoint related to illness. But really, this is the group that is really, I think, going to help us move healthcare into a different environment. Because they're looking to partner with physicians to improve their health care. They're coming in with information and sitting down and saying, how is it that I can get better with this condition I've been diagnosed with and improve my overall health? Next, you have the out and about. This group is really a small segment that really is looking for alternative health care and really outside of our normal avenues, whether it be acupuncture or other areas. But certainly is driving medicine to look at those alternative methods and see how those affect our traditional healthcare delivery systems. And then really last, it's the sort of the shopping savvy. This is the group who really is cost conscious and really is trying to drive value. And right now, that group really is represented highest by the millennials, but I think we'll continue to see that rise over time. When you look at healthcare in general, really value is one of the things that everybody's looking at. We're seeing it in a total different way. Everyone wants to say, how do I get the most highest quality service at the best cost when we're looking for those services? And I think really that's what you're seeing healthcare trying to revamp itself in terms of being more of a service-oriented industry. I think when you look at that, you look at some of the statistics that are here, and I'll just point out a couple. That really, those who have a primary care doctor is about 78%. Couldn't emphasize enough how important having a primary care doctor is in terms of overall health for patients. It really does guide everything in terms of specialist utilization as well as cost. If you look at the number of folks who had a routine visit in the past year, it's about 65%. That really hasn't changed since 2008. And one of the stats that's really important to me here is that you see that in 2009, 19% of the population participated in a wellness visit. Today it's about 10%. And despite what we say regarding wellness and the importance of wellness, the importance of good choices, we'll talk some about that as we go forward, we're still not seeing to grasp that with patients. That importance of how we get folks participating in wellness programs in your businesses, in your industries, and really how we get that partnership to decrease overall costs. So one of the things, here when you look at is how do we make choices in where we seek services? And as a population, one of the things that's interesting is on our website for Norton Healthcare, we have 800 plus quality metrics. So you can go on the website and see what applications there are, the rate of those, and all that information is available. But interestingly, patients still choose services by a relationship with a friend, a relationship with a previous experience. And so it's not necessarily still a data-driven experience, but it's an experience of my neighbor had a hip replaced by Dr. X, and Dr. X did it great for me, regardless of the fact that Dr. X may have had lots of complications on other procedures. That patient saw that as a good experience. And so we still are in an area where we choose our healthcare services based on that personal bias, rather than we do with reaching out to looking at data and making those decisions. I do think we're going to see that change in the next 4, 5, 10 years. I think we do that the same way with hospital services. I have a friend who's been to that hospital's done well for them, so that's where I'm going to go. But it does seem that on a health insurance standpoint, it's more of a 50-50 mix. You may seek an expert, seek an agent, someone to help you do that. And I think because sometimes those are not often things that patients have a lot of experience with, and so they seek that advice from the outside group. You know, as we look at health reform, one of the things that I think I look at this, and certainly we talk about this on a daily basis, is there are tremendous challenges in how we reform a system that represents 17% of our GDP. And so in looking at that, I know I look at that as I have many years to hopefully continue to work before I retire. But in looking at that, I look at that as a challenge because I think there are tremendous opportunities in how we continue to improve the services we provide for patients. And one of those things really is that patients want to be well, and from that regard, we have to change how we educate patients, how we get patients engaged, because specifically, one of the things we really never do is teach people how to use a healthcare delivery system. And I think that's really an opportunity for us in the future. I'm going to talk a little bit more about that, but right now I'm going to turn it over to Jeff and let him talk a little bit more about specifics around health.
Thanks, Dr. Hester. I appreciate the opportunity to be here this afternoon as well. I thought what I would do to cover some rather complex legislation, as Steve said before, some 3,000 pages, is give you the Reader's Digest version, if you will, of what we've seen to date with the Accountable Care Act and some of the more significant provisions that will come into play starting in 2014. Get to the first slide here. What I've outlined here is some of the more significant provisions that took effect starting in 2010 and a few in 2011, 12, and we're seeing some already this year. Some of these may be familiar to you already. You can't pick up a newspaper these days without hearing something about the Accountable Care Act. The first one, I think, probably had an impact on many of you here today. I happen to have a 24-year-old son. He's working, but he's saving money on his health insurance premium because he's still covered under my plan. So dependents can stay on their parents' plan until age 26, regardless of their marital status or even if they're not claimed as a dependent on your own taxes. Lifetime limits is the next thing that has been impacted by the Affordable Care Act, and that prohibits the lifetime dollar limits on the essential benefits for all fully insured health plans issued or renewed after September of 2010. And that date's somewhat important because of something called grandfathered plans. If you're an employer and you have not changed the plan design for your plan since sometime after September of 2010, you could be grandfathered and exempt from some of these provisions. But that's really only a small percentage of the group business that we see, around 10, maybe 12% of the business. Next is pre-existing conditions. And plans can no longer impose pre-existing conditions for children that are under age 19. Now, I'll talk about what happens next year in 2014. That's a major impact in 2014, the elimination of pre-existing conditions. Preventive services. New policies must cover the full cost of preventive care recommended by the U.S. Preventive Services Task Force, as well as recommended immunizations, preventive care for infants, children, adolescents, and additional preventive care for women. Next thing is rather significant too from the carrier standpoint, and that is minimum loss ratios. And starting in 2011, for individual insurance policies and small group policies, carriers now have to guarantee a minimum loss ratio, that is the amount that they spend on claims, minimum of 80% for individual and small policies, and a minimum of 85% for large policies. And some of you business owners may have been the benefactors of some of the refunds. Those are done on an aggregate basis, state by state, for fully insured blocks of business. And then I mentioned premium rate reviews come under very high scrutiny. We're a highly regulated organization and industry, and premium rate increases of 10% or more come under public justification for all rate filings and for formulas. Small employer wellness plans. I mentioned this is an interesting one. The Affordable Care Act actually provided or created a $200 million 5-year program for small businesses to create wellness programs, but unfortunately those provisions were never funded by Congress. State exchange grants is the next one mentioned here. Started in 2014, and I'll talk about this, you'll start to see public exchanges, and the Affordable Care Act created Health and Human Services awarded grants to states to help take the lead in developing new information technology needed to operate the health insurance exchanges. And Kentucky, as most of you know, has elected to operate their own private or public exchange. They've hired, I believe, Deloitte to build the administrative system to do the comparisons and the electronic offerings and enrollments, etc. And it's not an inexpensive proposition. Employer W-2 reporting. Beginning this year, most employers will be required to report the cost of employer-sponsored coverages on their W-2 forms provided to their workers. And I think the thought behind that is next year, in 2014, when there's an enforcement, a mandatory enrollment for health insurance coverage or some penalties that I'll talk about, that'll give the government some indication as who's covered and who's not covered. And then the last one that I put in here is an interesting one, is nutritional information. Many of you have probably noticed walking into large chain restaurants that you see nutritional content and calories and things of that nature that are listed on menus, and a lot of that was required as part of the Affordable Care Act. Looking ahead to 2014, we see really some of the biggest components of the Affordable Care Act, some of the most profound ones that will come into play that will impact our industry. It'll impact providers, insurers, and individuals. The first is exchanges. And as I mentioned, public exchanges will come into play in 2014, providing a new way to obtain health insurance. And I'll examine the exchanges a little bit more in detail in just a moment. The next major component in 2014 is the individual responsibility. And that people will have an individual responsibility to obtain coverage or face penalties if they don't. And again, I'll talk a little bit about that and take a closer look at what's known as the individual mandate in an upcoming slide. The next two things here were the biggest impact to the third-party payers in the insurance industry, and that is elimination of pre-existing conditions and guaranteed issue coverage. Starting in January of 2014, all carriers have to offer guaranteed issue coverage with no pre-existing conditions. And the industry's perspective was, yes, we can do that, but only if there's an enforceable mandate and individual responsibility, so that we don't end up insuring the building burning, the burning building at the time of need. So individual responsibility was an important part of the legislation, although you'll see, I think in a future slide, that the individual penalties will phase in, and in the first year they're actually quite modest. Annual limits on essential health benefits are prohibited. Waiting periods for new employees will be limited to 90 days or less. From a wellness perspective, insurance carriers, and group health plans can offer wellness incentives up to 30% of total coverage costs. And there's also a component called essential health benefits that plans have to cover. There's 10 different categories, including hospitalization, emergency services, prescription drugs, among others, that have to be embedded that make up essential health benefits. The next two things are impactful for those of you that are policyholders, business owners, or even individual policyholders, and that's reinsurance and premium taxes. And that there are new taxes and fees to pay for the expanded and subsidized care. You may know that in the exchanges there will be subsidization for people that exist on up to 400% of the federal poverty levels. There had to be a way to pay for guaranteed issue coverage, expanded coverage, the expanded Medicaid, those types of a thing. And so what we'll see is two major provisions: reinsurance, which will impose some $25 billion of taxes funded by individual and group health plans assessments per year in the years 2014 through 2016. And then premium taxes, a non-deductible premium tax will be imposed on insurers, starting with $8 billion in 2014, growing all the way to $14.3 billion in 2018. And after that, it's going to be leveraged up from that point in time. The next thing for small business owners is going to be quite impactful, and that's rating restrictions, or what I call, or others call, modified community rating. Today, in small businesses, when you buy health insurance, there's a range of rates, and that range is going to be compressed substantially in 2014. It's the good news and the bad news. For those of you that may have coverage in a group that may be an older group that may not be as healthy, you may look forward to actually some premium reductions. But younger groups and healthier groups are going to be looking at fairly substantial rate increases as this compression takes place because of modified community rating. No longer will carriers be able to rate on a number of different factors that we rate on today, but we will be able to rate on several different factors, including smoking as one of those factors. And then the last thing mentioned on this page is the Medicare minimum loss ratios. As many of you know, Humana is very big in offering private Medicare Advantage programs, and Medicare Advantage programs starting in 2014 will also have to offer a minimum loss ratio of no less than 85%. Talk just a little bit about the exchanges. One of healthcare's biggest changes involves creating a new purchasing arrangement known as exchanges. There'll be separate exchanges for individuals and also for small businesses, known as the SHOP, or the Small Business Health Options Program. Kentucky is running their own public exchange, and that will start in January 2014 with open enrollment starting in October of this year. Employer participation in the SHOP until 2016, states will have the option to define small employers as 1 to 50 workers. In 2016, it will be expanded to groups that have as much as 100 employees, and after 2017, states could choose to offer it to large employers through the SHOP. I mentioned the individual responsibility and the requirement of enrollment, and I don't know if you can see this on this particular slide, but individuals are required to obtain coverage or face tax consequences. In 2014, the tax consequences are the greater of only $95 or 1% of income. And that scales up from there in subsequent years. After 2016, penalties increase annually by the Consumer Price Index. So it's a rather low hurdle or low penalty in the first couple of years, and that's a concern to the insurance industry, is that many of the young and invincibles may avoid the individual mandate, but of course with guaranteed issue and waiver of pre-existing conditions, we'll see an influx of people that heretofore have not had access to health insurance. Let's see here. There's very few exceptions also to the individual mandate. There are some exceptions for financial hardship and religious objections, but those will be few and far between. And then one of the last things I want to talk about is for employers that have 50 or more employees. They will, and it's equivalent employees, that's an important clarification here. You may have 45 full-time employees and 10 part-time employees, but those part-time employees that work 15 hours, 10 part-time employees that work 15 hours per employee actually count as five full-time employees. So now you would have the equivalent of 50 full-time employees. If that's the situation, you're not required to offer coverage, but you will pay a penalty if you don't. If an employer chooses to offer coverage, coverage must meet the two-part test. It must meet the minimum value of the plans that are offered, a minimum actuarial value, and most of the plans that you're seeing out there in the marketplace do today. And it also must be affordable to your employee population. That is, it can't exceed 9.5% of their income that they obtain from the employer. So the larger employers will have that choice to make as to whether or not they want to pay or play. And if the employer does offer the minimum essential coverage, but there's at least one full-time employee that is receiving subsidized coverage through these exchanges, then the employer will face the lesser of either $3,000 for each full-time employee getting coverage on the exchange, or $2,000 for all full-time employees, excluding the first 30 full-time employees. So it's complex. I admit it. It's going to be hard for us to understand and to administer as well. There are some software applications that we'll have available to help small employers and large employers deal with this, to kind of go through this decision tree. So don't worry, there'll be plenty more information about this. And then regardless of what happens in terms of implementing healthcare reform, we'll be there working with the businesses and individuals to make sure that the reform law takes effect, and we'll continue to advocate for affordable and quality health care, and working with our provider partners as well to change the way that health care is delivered in a more efficient, effective manner. I'll turn things back to Steve.
Thanks, Jeff. I'm just going to go through a few things of how I think that we'll see changes for patients here coming into the future. And one of the things you do hear a lot about in the Affordable Care Act is you hear the word accountable. And the real question is, who's accountable for care? Is it the physician, is it the provider, the hospital, the insurer, the employer, the employee, the patient? And so as we look at transforming our healthcare delivery system, this is a key question that we as a society will have to answer. Primarily because when you look at it as a simple example, we'll take the flu shot. When you look at the number of folks who get the flu shot, lots of evidence there to show that it decreases morbidity and mortality. But there are a lot of folks who still refuse to do that. So that's a small example when you look at a broader scale of things, as I've listed here, when you look at smoking, tobacco, alcohol use, all the things that we know contribute to bad health outcomes. And so these will be questions that I think will be a key part of going forward in terms of how we intervene and help patients to get to a healthier place, and really ultimately help society. Things that you'll see in the future that will become more prevalent, continued increase in transparency. I think from an electronic medical record standpoint, you're going to see more folks putting information in the public domain, whether it be websites, social applications, those types of things, in terms of really helping drive change in behaviors of patients, as well as helping drive change in providers. I think in terms of what we see in terms of consumerism of healthcare is really much more of a drive towards that. I've had an experience at Apple. How does that experience translate to an experience in healthcare? And and how do we change those things? And I think that we're going to see patient engagement in a whole different way. I think from an alternative cost structure standpoint, lots of disruptive innovations that will come in the market from that standpoint, whether it's care being provided as it may be in a Walgreens, or provided in a different setting, nurse practitioners playing a much larger role in care. And today, when you poll the population, 50% of folks are comfortable seeing a nurse practitioner. That's increased year over year. And so how do we use different providers to provide different levels of care and educate the population differently, again, so they can be a healthier group? And I think consolidation, not just in the healthcare hospitals, but you're starting to see that along with physician groups. You're starting to see that in the medical industry, whether it's supply industry, electronic medical records, those types of things. We've seen that in other industries. As an interesting stat, four of the airline companies represent 85% of all miles flown for the airlines. 6% of the banks represent 85% of the holdings. You see a significant consolidation in a lot of other industries, and I think you're starting to see that from a healthcare perspective as well, is how you get that consolidation over time. Some of the things that will be more specific to clinical delivery, I think communication coordination. I know that we have a product called MyChart, which allows patients to connect directly into their electronic medical record, get results back, be able to follow those online, and have email communications with their physicians. That's going to be a key for the future in terms of the way we see patients interact. I think improved access, whether it is through video, emails. We see folks getting video visits now, and I think there are a lot of things that can be done specifically around education, and then looking at populations who maybe not have access to health care, specifically rural Kentucky. It's a great example for that. Continuing to focus on prevention and diagnosis, early diagnosis, but then right care and right locations. It's not just having those visits and how do you get folks who need to go to the emergency department to show up there, but someone who's not necessarily ill enough to come there to make it to an immediate care center or their primary care office. I think generic medication is another one of those where there's a significant amount of spend in healthcare on pharmaceuticals. How do we get folks to understand that generic medications can be a good option for them and really don't have a decreased effectiveness and really can help us overall curb healthcare costs? And I think, readmissions are one of those things that is talked a lot about, and it becomes a partnership. Because when you discharge someone from the hospital, how do you help that patient stay out of the hospital? It's going back home and making sure they have the services at home to support them. They have family who's near. They have access to medications, have access to services. And I think, lastly, when you look at this list, one of the things that we've done a lot of in healthcare is work towards standardization. And there are lots of things that are good about standardization because you decrease errors in doing that. But at the same time, what we're really looking to do is decrease variation, meaning that if you come in with a condition, all of these things happen the same every time. But what we really need to do is make sure that care is personalized. Because as an example, as a physician, if I were to be diagnosed with diabetes, the education I need prior to being discharged from the hospital is far significant than someone who doesn't have a high school degree. And so how do we look at those from a services standpoint and make sure we're meeting the needs of the population based on education? And that'd be one of the things that I think is so important, just to continue to emphasize that we look at our healthcare delivery system as something everyone knows how to use. And I can tell you from practicing in the emergency department, I would say, what made you come here today? And it was typically my mom told me. And you get a 20-year-old who shows up and really didn't need to be there, could have saw a different level of care, but didn't know how to use the system. And so I think that's something we all collectively have responsibility from the population standpoint, is how do we collectively educate those to use our healthcare system better. Lastly, I like to look for opportunities in other industries to see how it might affect or apply to healthcare. And there's a book written by John Vogel, the founder of the Vanguard Fund. And in the preface of the book, he tells a story where Joseph Heller, the author of Catch-22, and Kurt Vonnegut, the author, are talking. And again, they're at the party of a hedge fund manager, and Kurt Vonnegut says to Joseph Heller, doesn't it upset you that this hedge fund manager made as much money in a day as you made your entire life for Catch-22? And his response is pretty profound. He comes back and says, it doesn't bother me at all because I have the satisfaction of knowing I had enough. And that ends up being the title of the book. And I think as we look not just at healthcare but other things, healthcare is one of those things where we often think more is better. And it's one of those things where it really is a partnership with the provider. It's a partnership to try to find out how you solve the problem. But oftentimes more is not better, and sometimes that's what leads us down paths to continue to increase costs. So that's sort of our challenges for the future.